Rahim. Good morning, Mr. Chairman, my dear professors and colleagues. In my talk, I will focus on how to manage patients with advanced heart failure and cardiorenal syndrome. The agenda of my talk will include, firstly, what are the different types of cardiorenal syndrome, and then what's the mechanisms and pathophysiology of this syndrome. And especially, I will focus on type 1 and type 2 and how heart dysfunction can lead to kidney injury. And then what are the diagnostic modalities, either biomarkers or imaging modalities that help in the diagnosis, and finally, how to treat these patients. We know that the interaction between the heart and kidney is bidirectional, and cardiorenal syndromes include disorders that involve both heart and kidneys, in which acute or chronic dysfunction in one organ may induce acute or chronic injury in the other organ. And we know that we have 5 types of cardiorenal syndromes, type 1 and type 2, the cardiorenal syndromes in which acute or chronic dysfunction in the heart can lead to acute or chronic dysfunction in the kidney. So type 1 cardiorenal syndrome, like acute heart failure, can lead to acute renal failure and acute kidney injury, or acute coronary syndrome helps in injury of the kidney. Type 2, in which chronic heart failure and chronic LV dysfunction lead to progressive chronic kidney disease. Type 3 and type 4 are the renocardiac syndromes, in which type 3, acute renal failure, may lead to overload and exacerbation of acute heart failure. Type 4 is chronic renal failure, may lead to a cardiomyopathy or many chronic kidney disease associated renal diseases. And type 5, in which systemic illness can affect both the heart and kidney, like amyloidosis, sepsis, and sometimes liver cirrhosis affect both. What are the mechanisms and how heart disease can lead to chronic kidney disease or kidney injury? Firstly, it could be hemodynamically mediated damage due to low cardiac output, due to decreased renal perfusion, decreased renal blood flow. And we know that the kidney receives at least 25% of the cardiac output. Early in heart failure, there is a compensatory mechanism through vasoconstriction of the efferent arteriole to preserve glomerular filtration rate and to preserve the filtration fraction. However, with advanced heart failure and with extreme activation of the RAS system and the sympathetic system, vasoconstriction of the afferent arteriole occur, and then this leads to decrease the filtration fraction and starting renal dysfunction. Also, we have increased venous pressure. The increased systemic venous pressure leads to increase the renal interstitial pressure and impair more and more the renal blood flow. And also the presence of sometimes ascites increase the intra-abdominal pressure and lead to renal, compress actually the renal veins and exacerbate the renal congestion and impair more and more the renal blood flow. And here we can see that worsening of the renal function increase significantly with increasing the central venous pressure and the systemic venous pressure. The damage could be also humorally mediated. As we said, with an activation of the RAS system, vasoconstriction of the afferent arteriole can occur and decrease the renal blood flow. But also with RAS and sympathetic nervous activation, there is increased proximal tubular reabsorption of sodium and water, which lead to volume overload, worsening congestion, and oliguria. The damage could be also immune-mediated through many inflammatory mediators, cytokines, endothelial dysfunction that lead to renal damage. And number 4, the exogenous factors like contrast in coronary angiography and PCI and initiation of ACE may lead to renal dysfunction, and overdiuresis may increase the intravascular volume and impair more and more the renal function. What about the prevalence? Is it common? Yes, it's really common. In chronic heart dysfunction and chronic heart failure, in the SHARM study, we have actually 30 to 40% of patients has glomerular filtration less than 60 milliliter per minute. And there is a stepwise increase in the incidence of mortality and rehospitalization for heart failure with decreasing the glomerular filtration rate, with wide separation of the curves when the glomerular filtration rate decreased below 60. In acute heart failure, and this is from the database, more than 60% of patients has glomerular filtration rate less than 60%. And also there is a stepwise increase in the incidence of events, mortality, and hospitalization of heart failure with decreasing the glomerular filtration rate. So how to diagnose renal dysfunction in those patients? The standard is to use serum creatinine, which is a biomarker of glomerular injury secreted by secreted by skeletal muscles, and the definition of acute kidney injury according to the Kidney Disease Improving Global Outcomes definition. They diagnose acute kidney injury with there is increase in the serum creatinine more than 0.3 milligram per deciliter within 48 hours, or increase the serum creatinine 1.5 times the baseline in less than 7 days, or oliguria with a urinary output less than 0.5 milliliter per kg per hour within 6 hours. And this staged into 3 stages. Stage 1, when the increase of the serum creatinine between 1.5 and 1.9 times the baseline, or oliguria between 6 and 12 hours. Stage 2, if there is a more elevation, more than 2 times the baseline up to 3, and oliguria more than 12 hours. And stage 3, if there is an elevation more than 3 times or more, or if there is need for renal replacement therapy, or if there is anuria more than 12 hours. So the definition, use the standard serum creatinine and urinary output. But we have more biomarkers of renal injury like cystatin C, which is produced by all nucleated cells and has proved in many studies that it has significant prognostic value and it can predict mortality and hospitalization for heart failure. And we have biomarkers of tubular injury, and the most famous is NGAL, the neutrophil gelatinase associated lipocalin biomarker, and this biomarker is the most upregulated protein secreted by the kidney in case of acute kidney injury, and extensively studied, and it has significant diagnostic and prognostic value in patients with heart failure. And here in the GALAN trial, serum NGAL at the time of discharge can predict the 30 days events, either heart failure, hospitalization, or mortality, better than BMB. And here creatinine and GFR couldn't actually predict the outcome at 30 days like serum NGAL. And the addition of this biomarker to BMB increase the predictive value with a hazard, actually make the hazard ratio 16 to predict 30-day mortality and 30-day heart failure hospitalization. There is actually other biomarker, which is really very important biomarker, and it's available for clinical use even in the United States for detecting acute kidney injury, which is the combination between urinary tissue inhibitor of metalloproteinases and insulin growth factor binding protein C, which is a cell cycle arrest biomarker. This biomarker, it is superior than all other biomarkers to detect acute kidney injury. However, till now, the relation between this renal biomarker and heart failure is not established, is not well studied in heart failure studies. So this is regarding biomarkers. What about imaging? We can use echocardiography, importantly, to measure the right atrial pressure by just measuring the IVC size and how it behaves with respiration. And there is also intrarenal Doppler ultrasound to detect how the kidney is congested by simultaneously measuring the intrarenal arterial and venous flow. And we can see here, this is a venous flow, which can be categorized either it's continuous flow or it is discontinuous, but it's biphasic. Here it reached 0, or it's monophasic. And here how the renal venous pattern can predict the outcome, and actually discontinuous monophasic flow is associated with significantly higher events, mortality, and heart failure hospitalization. Also, you can measure very easily the intra-abdominal pressure just by connecting the urinary catheter to a pressure transducer, and if the pressure is more than 5, so the intra-abdominal pressure is high. What about treatment? How can we treat those patients? We know in acute heart failure and cardiorenal syndrome type 1 is very important to assess the volume status, as we know, and the degree of perfusion to categorize the patient, either it's wet dry, warm wet, or cold dry and cold wet. If it's congested and evidence of volume overload, so we can start diuresis and may use some vasodilators. If the patient shows signs of hypoperfusion, he will need inotropes and vasopressors. Let's start what are the available decongestive strategies. As we know, firstly, diuretics, which is the cornerstone in the management, and it provides immediate relief of heart failure symptoms. However, there is no benefit in short, even, or long-term mortality or hospitalization, and the loop diuretics are the preferred, and torsemide may be better because it has more predictable oral bioavailability and longer half-life. How can we use it and what dose? The dose heart failure study showed that there is no difference between IV infusion or bolus regarding improving symptoms or worsening renal function. So you can both can be used equally, but there is a trend that high dose of IV diuretics is associated with significantly lower symptoms compared to low doses of diuretics, and importantly, once you are monitoring your patient, you should have careful clinical assessment to assess the degree of plasma refill. You are diuresing the blood volume from the intravascular, and you are waiting till it's refilled from the interstitium. So this will need careful monitoring of the kidney function to avoid decrease in the intravascular volume, which trigger actually activation of the RAS system and may lead to worsening of renal function. And we know that aggressive actually decongestion, even with some elevation in kidney function, is associated with better outcome than having volume overload with normal kidney function. So we may accept some increase in the renal function in order to decongest the patient, which have better long-term outcome. The major challenge for our patients with cardiorenal syndrome is diuretic resistance. What are the mechanisms of diuretic resistance? Firstly, it's diminished oral bioavailability. We know that furosemide has oral bioavailability of 50%, which is decreased significantly when you have gastric congestion. So it decreases the absorption of the diuretic, and then impaired drug delivery. Furosemide should be secreted through the proximal renal tubule to act from the urinary side of the kidney. And it's 95% bound to albumin. So if you have hypoalbuminemia, so it will not be secreted, it will not be transported to the kidney. So correction of hypoalbuminemia will improve the diuretic resistance. Sometimes also the use of non-steroidal anti-inflammatory drugs can inhibit the secretion of furosemide, so stopping this non-steroidal will improve the drug. Glomeruli is decreased, which actually lead to more and more diuretic resistance, and the most famous mechanism of diuretic resistance is the distal renal tubular hypertrophy and the breaking phenomena, which can be overcome by sequential nephron block and initiation of thiazide diuretics, some of the strong thiazide diuretics like metolazone, and also adding mineralocorticoid to inhibit also the renal tubular absorption at the distal tubules. So this will improve the urinary output and lead to more and more diuresis. What about ultrafiltration? Many studies actually studied the use of ultrafiltration and compared to diuretics in patients with acute heart failure. The UNLOAD study showed that it has a favorable effect on weight loss more than diuretics. However, the CARES heart failure study showed there is no difference between ultrafiltration and diuresis. Actually, it was associated with significant increase in the serum creatinine and higher rate of serious adverse events, which is confirmed in the last AVOID heart failure trial. In this trial, there is an increase in the serious adverse events, mortality, infection, anemia, and bleeding with ultrafiltration compared to diuresis. So we use only ultrafiltration if the patient has refractory congestion and fail to respond to diuretics, and it's a class 2B in the recommendation. But we can go for a renal replacement and dialysis if the patient is overloaded, and also there is an evidence of acute kidney injury and rising creatinine, which actually has class 2A recommendations. What about neurohormonal modulation in acute heart failure and acute and type 1 cardiorenal syndrome. Although that it theoretically makes sense, but most of the studies did not show benefit in terms of prognosis and mortality, like with the use of V2 receptor antagonist or nizritide in the Everest and the Ascend trial. Also, we know that the use of inotropes is associated with increased mortality, increased the risk of arrhythmia. So we can use only inotropes if there is an evidence of hypoperfusion and no response to diuresis with low blood pressure. So at that time, you can introduce inotropes and vasopressors because it's associated with actually increased mortality in heart failure patients and acute heart failure patients. Low dose dopamine, we know the story that low dose dopamine stimulate dopaminergic receptors in the kidney, so it increases the urinary output. But definitely it increases the urinary output, and it may have transient improvement in the renal hemodynamics and renal physiology, but there is no evidence that it improves mortality or it has any impact on the prognosis in this, in many studies and in this latest meta-analysis. In type 2 cardiorenal syndrome, with patients with chronic heart failure and renal dysfunction, we have a strong evidence that the usual beta blockers, ACE inhibitors, ARNI, and mineralocorticoid antagonist is beneficial in chronic kidney disease stage 1, 2, 3. In 4 and 5, the evidence is weak of benefits, not like our patients with normal kidney function or early renal dysfunction. But importantly, the use of ACI and ARBs in those patients is associated with significantly lower mortality compared to patients who did not receive ACI. So we should start running ACI or ARBs in those patients even if there is renal dysfunction. But how can you use it? We know from the guideline that you may not use it or use it with very, very cautious if the serum creatinine more than 2.5 and GFR is less than 30. But if the serum creatinine is less than 2.5 or the GFR is more than 30, you can start ACI or ARBs. You can expect some increase in the creatinine and kidney function. If the creatinine increased less than 50% of the baseline and GFR is still less than 25, so you just follow up the kidney function and serum potassium. If they increase more than 50% of the baseline, so you can halve the dose and monitor kidney function and potassium. But if the creatinine increased by 100% of the baseline and there is a hyperkalemia with a serum potassium more than 5.5, so at that time you can discontinue ACI or ARBs. What about mineralocorticoid? Also, you cannot use it if the serum creatinine is more than 2.5, but you can use it if the serum creatinine less than 2.5 and the GFR is more than 30. Just monitor the serum potassium, and if the serum potassium increased more than 6, so you should stop mineralocorticoid antagonist. What about sacubitril valsartan? We know that there is no dose adjustment. You can use it even in the presence of renal dysfunction. It's contraindicated if the GFR less than 10. But if the GFR in patients with severe renal dysfunction, just start with lower dose, 50 milligram twice daily, and follow and up titrate gradually with careful monitoring of kidney function and serum potassium. We know the new data about SGLT2 inhibitors, and here the EMPA-REG outcome trial, the empagliflozin was associated with 39% relative risk reduction in the renal endpoints and the incident or worsening nephropathy. And even in the DAPA heart failure study, we will find that 40% of the patients had glomerular filtration rate less than 60. And the beneficial effect of dapagliflozin on mortality and heart failure hospitalization exists even if the glomerular filtration is less than 60, but we know that its effect, or actually it's contraindicated, or it cannot work if the GFR less than 30. Finally, about device therapy, there is actually the evidence is strong to use CRT or ICD in patients with stage from 1 to 3, but the evidence is really weak in advanced renal disease and mechanical circulatory support, renal dysfunction or renal injury renal failure is not a contraindication for VAD, but dialysis is absolute contraindication for VAD. My final take-home message is that renal dysfunction in patients with heart failure is really common, range between 40, sometimes 60% of the patients. The pathophysiology is really complex. It's an independent predictor of outcome in patients in acute and chronic heart failure with preserved ejection fraction and reduced ejection fraction. Plasma NGAL at discharge is a significant predictor of outcome in patients admitted with acute heart failure. And finally, careful assessment of the renal function and electrolytes and assessment of the degree of refilling of the intravascular volume with the use of diuretics is very important to avoid more and more worsening of renal function in those patients. Thank you.